Good afternoon, everyone. This is Carol Dietz, the Antibiotic Stewardship Task Lead, Regional Lead for the New England QIN-QIO. Welcome. We'll be exploring one provider's community-based approach to antibiotic stewardship today, which will give you some examples as to how to start to implement an antibiotic stewardship program in your office, in your urgent care center, in your emergency department, or in your hospital. Or if you already have started the journey, you will hear examples how to enhance your program, your antibiotic stewardship program. Before we get started, I'm going to quickly review a few housekeeping items. The call is being recorded, and the recording will be available within a few business days on the New England QIN-QIO website. The phone lines will be on mute while the speaker is talking, but we will unmute the lines after the presentation for questions and other comments that you may have to share with the community. And we'll be giving you some instructions how to ask your questions at that time. Although the lines will be muted, we still would like to you to actively participate during the session using the chat function. My colleagues, Maureen Masella and Alyssa Dacunia, I told you Alyssa I'd screw it up, will be monitoring the chat box and responding to your comments in real time. So don't be shy. This is a true learning session for all of us. We'd love to learn more about your efforts and how we might best support you to going forward. And we'd also love to hear your thoughts about what the speaker is saying. So as I mentioned, I'm Carol Dietz. Maureen and Alyssa will be monitoring the chat box for you. And Kimberly Knox is the infection preventionist and control coordinator at the Milford Regional Medical Center in Milford, Mass. And she's been there since 2013. She is a member of the Massachusetts Department of Public Health's Antimicrobial Resistance Subcommittee, the Massachusetts Department of Public Health Hemovigilance Technical Advisory Group, and she's also a member of APIC. And she's also certified in infection control. Now, Dr. Michael Newstein was supposed to be on this webinar today, but because of a family emergency, he is unavailable for us. So Kim will be our presenter for this session. It's important to note that Kim does not have any conflict of interest or any disclosures. So let's start using the chat function to make sure that you can send us a message and receive a message. So I'd like you to type in your name and the role along with your organization and the state that you're working in. So Maureen and Alyssa, let's keep an eye out, and let's see how many people can respond to that question. So the objectives for today, upon completion of this session, the participants will be able to recognize the value of antibiotic stewardship, explain Milford Regional Medical Center's community-based approach to antibiotic stewardship, and state how participating in the New England QIN-QIO's Antibiotic Stewardship Collaborative can support your goals of implementing a sustainable antibiotic stewardship. So for those of you who were on our webinar last week on March 22nd, welcome back. For those of you who were not on our webinar, which was titled Getting Smart, Antimicrobial Stewardship Across the Continuum, welcome to today's webinar. During our last webinar last week, we highlighted how antibiotics are truly life-saving medications and are one of the most important advances to modern medicine. But whenever you take an antibiotic, you are also creating an antibiotic resistance within your body, so that the next time you may need an antibiotic that is much more toxic to kill the germs due to the resistant bacteria that have been building up in your body. This is a truly vicious cycle. The CDC is working to reduce unnecessary antibiotic use in all settings. The new focus is on outpatient settings where they have found that 30% of the antibiotic prescriptions are unnecessary, which equates to 47 million unnecessary antibiotic prescriptions per year. That is an overwhelming number. 47 million unnecessary antibiotic prescriptions per year. Another area of focus from our last week's webinar was antibiotic stewardship and why it's so important now. Antibiotic stewardship is ensuring that all patients receive antibiotics only when needed. And if it is indicated, it will be with the right drug at the right dose for the right duration. The primary goals are to improve clinical outcomes, avoid adverse effects, and minimize the emergence of antibiotic resistance. So why now? Why is it so important now? Well, for the past 40 years, we have been playing leapfrog with antibiotic resistance. We would create an antibiotic, and the bacteria would create the resistance within years of the drug's creation. So then we would create a new antibiotic, a more toxic antibiotic, and again, the resistance would not be far behind. Now the game is ending. Bacteria develops resistance so quickly that pharmaceutical companies have decided making antibiotics is not in their best interest. So there are infections moving across the world for which out of more than 100 antibiotics available on the market, there might only be 2 antibiotics that might work to kill a bacteria. And again, will have some real toxic side effects for that patient. Or there may only be 1 antibiotic that may kill the bacteria, or none at all. As you can read on the slide, this is the title of an article that was written in January of this year, 2017, about a Nevada woman who had died from a superbug that was resistant to all available antibiotics in the United States. She was deemed incurable after being tested against 26 different bacteria. This is now. It's real. It's here. In order to achieve the goal of reducing antibiotic resistance and antibiotic misuse, we need a community solution. There needs to be antibiotic stewardship throughout the healthcare continuum in all healthcare settings. In 2014 and 15, the CDC released the core elements of antibiotic stewardship for the acute care hospitals and the nursing homes. Both of these use 7 core elements in their stewardship. In November of 2016, the CDC released the 4 core elements of antibiotic stewardship for the outpatient setting. The elements of these 3 stewardships are similar, so that as a community, the settings can work together and help each other achieve a community-based antibiotic stewardship that focuses on reducing antibiotic resistance and antibiotic use and misuse. It's all about patient care and patient safety. So when we talk about the outpatient setting, who are we talking about? The core elements for outpatient settings focus on primary care clinics and their providers, emergency departments, outpatient clinics, urgent care centers, federally qualified health care centers, and outpatient pharmacies, plus physician offices and physician groups. These are the outpatient settings that we hope to engage. So when I talk about the 4 core elements, these are the 4 core elements from the CDC. Now, Kim, our speaker, will be talking into them much more in depth and about how they incorporated them into their antibiotic stewardship program, but I just sort of want to high-level review them so we're all on the same page. The first core element is commitment, being able to demonstrate your facility's dedication and accountability for optimizing antibiotic prescribing and patient safety. The second core element is the action for policy and practice, which is to implement at least one policy or practice to improve antibiotic prescribing, assess whether it's working, and then modify the process as needed. The third core element is tracking and reporting. You're going to be tracking and reporting antibiotic prescribing practices and then offer regular feedback to your clinicians and staff as to how things are progressing. And finally, the fourth core element is education and expertise. And this surrounds providing educational resources to your clinicians and patients on antibiotic prescribing and ensure access to needed expertise to clinicians on optimizing antibiotic prescribing. We have two asks of you today. We want you to, as you're listening to Kim's presentation, we want you to start thinking about implementing these four core elements into your facility. And if you already have started an antibiotic stewardship program, how you can enhance your program with some of the recommendations that Kim is going to be talking about. And we also would like you to share these comments and these implementations with us in the chat box. Our second ask, you're going to have to wait for that. That's going to come at the end of the presentation. So without further ado, I would like to introduce Kim Knox to talk about the Milford Regional Medical Center's antibiotic stewardship and how it's a cross-continuum journey. And Kim, I will be advancing the slides for you, so just let me know when you'd like to move on.
All right, thank you very much, Carol. And thank you to QIN-QIO, actually, for letting us participate in this program. We're so eager to work with you and have the support of this initiative, because not only have we been doing antimicrobial stewardship in the acute care setting since about 2010, but also we reached out to skilled nursing facilities and rehabilitation facilities in our service area. Shortly after that, we've been working with them. But we recently doubled the size of our emergency department, and just within the past few months have opened 3 new urgent care centers associated with our hospital. And we're eager for the education and the support to roll antimicrobial stewardship out to those practices as well as to physicians' practices within our service area. So thank you. So first of all, let's start about commitment. Now, I understand that we have more elements of the goals identified by CDC in acute care than in the long-term care and community programs. However, I think that there might be examples that can be used elsewhere. So our President and CEO at Kelly signed a letter of commitment stating that the facility and the agency will support antimicrobial or antibiotic stewardship activities. And just by the way, antimicrobial is just kind of a broader term because not only does it include antibiotic use, but also antifungal medications, antivirals, and some other elements. So I don't want you to be thrown by that, just it's antibiotic use and then some. So, and we dedicate necessary human, financial, and information technology resources. And in fact, my associate, Wendy Burke, has been working quite closely with IRL Solutions, not that we're endorsing any particular software program, but to see if we can develop reports that will be useful in guiding antimicrobial stewardship. Also, success has been indicated in programs that have a strong clinical leader. And we actually do in Dr. Michael Newstein. And he has been very effective in governing actually the activities of the Antimicrobial Stewardship Committee and other activities relating to infectious disease throughout our hospital. And we're really happy to have him working with us on this. And as you can see, this commitment goes from our house to the White House. So if you can advance to the next slide, please. To the White House. Just Obama administration actually released a national action plan to combat antimicrobial or antibiotic-resistant bacteria in 2015. And we hope that the current administration will also value the importance of this, because it really is critical to patient safety and actually, just to all of us. Next slide, please. So now I'd like you to share your thoughts about what ways you can provide outpatient providers that they actually can demonstrate commitment to the work that you are doing, and so that they can demonstrate dedication to and accountability for optimizing those antimicrobial or antibiotic prescribing and patient safety initiatives that you have. So I don't know if you're thinking about that. I'm sure when you type in your questions that those will be some things you can, either questions, concerns, or great ideas would be appreciated from you. Also, actions for policy and practice, and you can go to the next slide, please. So on these actions for policy and practice, implement at least one policy or practice to improve antibiotic prescribing, to assess whether it's working, and to modify as needed. In the next slide, which we may go to now, you can see some of the activities that we performed at Milford Regional Medical Center. So some of them were, we instituted front-end and back-end restrictions. In other words, some medications really needed approval to be ordered, or some of them needed approval to be continued beyond a specific date range. We also have formulary restrictions. We work, as one can imagine, very closely with our pharmacy and therapeutics department. And our pharmacy has been tremendous in supporting all of these activities. We have automatic stop orders and queues within electronic medical records. Now, those queues can be for ordering medication, but they also might be something for ordering a test. So, for instance, if one is going to do a C. diff test here at the hospital, we need certain criteria to be met. You know, the stool has to conform to the shape of the container. And one of the great euphemisms of all time, patients should have an elevated temperature, should have had at least 3 stools in the past 24 hours, and should have an elevated white blood cell count and elevated temperature, as I mentioned. So those are just some things we're looking for. Also, at this institution, we participated in a series of antimicrobial stewardship calls with Dr. Ajahn Srinivasan from the CDC's Get Smart for Healthcare activities, and now it's, Get Smart about viruses versus bacteria. And the websites are available here. If you go into the CDC's website, you can look at this address here and actually access that information. So that will keep you current, and certainly we use it to keep us current. Also, something we assessed was proton pump inhibitor use. I kind of jokingly say at Milford Regional that all roads lead to C. difficile, except I'm not really joking too much, because proton pump inhibitor use, which is actually recommended for things such as this-associated prophylaxis, so a patient doesn't get stress ulcers when they're in an ICU or in other parts of an institution that uses ventilators. They recommend that patients have these stress ulcer prophylaxis medications, but proton pump inhibitors increases a patient's risk of C. difficile. When you think about the other risk factors for them, long-term care facility, increased age, increased antibiotic use, all of these tie in together. So if we can minimize the risk of the proton pump inhibitor use, then it actually decreases a patient's risk for C. diff and for needing additional antibiotics to treat that. One of the things that we want you to think about with these proton pump inhibitors is just because a patient gets them in the hospital doesn't necessarily mean when they're discharged to the hospital to, for instance, a skilled nursing facility, that the need is still there. So we want people to be thoughtful about medications they're prescribing. And we try and be thoughtful about it as well, so that those medications, such as proton pump inhibitor, are discontinued before the patient leaves the hospital unless there's a clear indication for use. So that's something. Next slide, please. On actions also, the Joint Commission is really looking at antimicrobial stewardship in healthcare facilities. one of the recommendations is for rapid testing. If you can test a patient and have an early diagnosis, you can narrow the antibiotics or you can not have them at all. So some of the things we've done here is we have procalcitonin testing for patients who have either suspected community-acquired pneumonias or healthcare-associated pneumonias. We initially limited these to inpatient use, but then quickly saw some of the advantage to it and actually expanded the use of these tests to outpatient settings. The test occurs greater than 12 hours after a patient has developed symptoms of these pneumonias, and if the marker is less than 0.5 nanograms per milliliter, then that patient may have a viral, not a bacterial infection. Dr. Newstein often has talked about the fact that years ago people really assumed that most community-acquired pneumonias were bacterial in origin. But now that pneumococcal vaccines are so widely available to individuals, some of that thought process has changed, and many of these community-acquired pneumonias are viral in origin. And therefore, if you get an appropriate, if you get a procalcitonin test that has this lower level than, result, then actually the provider may be able to de-escalate or even discontinue antibiotics. Once again, if you can do all of that, it decreases the risk of the patient acquiring a secondary infection, such as Clostridium difficile. Also, there are current recommendations for shorter durations of treatment with antimicrobials or antibiotics for patients. Years ago, the thought was that patients needed approximately 14 days of treatment for pneumonias that were bacterial. Then, relatively recently, that time frame was shortened to 10 days, and now really the recommendation at our facility anyway is for duration of treatment to be 7 days and then kind of reassess what the patient needs. And one of the other things you can do with procalcitonin testing, even if they have bacterial pneumonia, is if their level is still high after they finish their 7 days of care, then you can reassess it, what treatments the patient needs. Remember that this is really, not for everyone, but it is something that's available. And not every hospital may be doing this, but you want to check with physicians in your area and see what their practices are. So, next slide, please. Maybe you can share your thoughts about policies and practices that could be implemented around antibiotic prescribing or prescribing such medications as proton pump inhibitors. So think about one policy or practice to improve antibiotic prescribing and assess whether it's working and modify as needed. Now, physicians certainly are in charge of ordering medications, but one thing that nursing staff and other clinical staff can do is if they have patients on antibiotics and they don't seem to be improving, we want to advocate for our patients, and they could at least share the information about, this patient's temperature is still elevated after being on this antimicrobial, they still have an elevated white blood cell count, and just, have people open lines of communication that they may need to rethink the appropriate treatment for that patient. Next slide, please. Tracking and monitoring of antimicrobial stewardship programs can be tricky. And it's not tricky in the sense of impossible to do, but we at this institution are working hard to find viable solutions to getting electronic reporting of the antibiotic use for patients. And some of that can be done electronically, and some of it cannot so easily. So it can be very labor intensive to get quantitative reports, reports that show how many antibiotics have been given to a certain period of time or, for over what duration of time. And one of the things that we've resorted to is once we determine which patients fit in the category of the report we want, it takes a lot of labor-intensive work, just reading those thoughts and determining how long these have been happening. But as I mentioned earlier, we are working with software programs at our facility, and I would love to hear what people are doing at their facilities and how they can help with that, and would love suggestions for how we can make the process easier and more consistent. So on the monitoring, though, one of the things that the Joint Commission says is you have to kind of report activities. You have to be able to demonstrate that you're doing it. Well, we have actually a very vigorous antimicrobial stewardship program here, and that includes a meeting that's really performed approximately monthly, that we take minutes, that we report the actions that we've taken and the findings that we have determined based on either some reports, whether they're electronic or physical kind of drug-free work. So our pharmacy has been fabulous about this. So the pharmacy director, Sue Ataki, developed a program with pharmacy students to review antibiotic usage. So Milford actually won a national prize from AmeriNet regarding this initiative, and we had shown a large reduction in some of the antibiotics we used. And that was the good news, because that's a patient safety issue. But we also reported that there were financial gains from this, too, because if you're reducing the amount of antibiotics you use inappropriately, or, maybe not as necessarily needed, then you can save some money. So remember, the goal of antimicrobial stewardship is not necessarily to reduce the amount of antibiotics used. What it is to make sure that the antibiotics that are used are appropriate for that patient. And when I say inappropriately, I just mean that, a patient who potentially has a viral infection, you want to be able to maybe determine that if possible, and also, just make sure that the patient's antimicrobial use is, as I said, appropriate for their organism, to make sure that patients start off with broad spectrum, that they can be narrowed to narrower spectrum antibiotics when lab results are available to you. So the pharmacy has helped us with that. And we regularly report that information to the Antimicrobial Stewardship Committee, to our physicians and nurses, and actually to outside agencies such as some of the skilled facilities with which we work. So if we will go to the next slide, please, we can see, are you thinking about data reports that you run to monitor prescribing? And do you have a forum to review prescribing practices such as, provider meetings or practice meetings? Once again, I would love it if you would share that information with us. So remember, when we're tracking and reporting, you're monitoring antibiotic prescribing practices and to offer regular feedback to clinicians. Or have clinicians accept their own antibiotic prescribing practices themselves. We want to be thoughtful about this. Next slide, please. When it comes to education and expertise, we're looking at, that's really kind of the fourth element, core element for outpatient antimicrobial stewardship practices. You want to think about educating prescribers, practitioners, staff, and patients on your antimicrobial program. And that may include information about resistance and optimal prescribing practices. Now, you may think, how are we going to do that? Well, here are some of the things that we've tried, and I think with some success. So for nursing and other staff and physicians, we have annual infection control updates that go out that are given during orientation and during updates available to them throughout the year. We do that in our OSHA annual update. We also educate individuals during committee meetings and trainings. And when one does education, you don't look at just what's available to you at that time. During that year, that situations can evolve in your region, the nation, the world. And you want to make sure that individuals have the information they need to deal effectively with circulating, emerging, or re-emerging infectious diseases. Physicians also get training through committee meetings and oral and written communications with the other medical staff. And patients and families, they're important also. We want to make sure that they have a good understanding of when an antibiotic is effective and really kind of conversely when it's not. Because we know that physicians in the community, in skilled facilities, and hospitals can actually get a lot of push from patients or their families for treatment, which may not be the most appropriate for an individual. We all know about individuals going to practices and saying, I really need an antibiotic when what they have is a common cold and the antibiotic won't be appropriate. Well, how do we get the word out to them? Well, some of the things that we have done is relied on actually the CDC's Get Smart about antibiotics and, viruses versus bacterial information. And we've published this, variations of this in our our patients handbooks that get distributed to all inpatients when they're admitted, and to give them some information. Also, on the hospital's website, we have various blogs and health information reference points for them. And we put the information there so the patient who's not an inpatient, that outpatient or that individual, that individual's families or visitors also have access to that information. So they stay current and understand what really should be treated with the antibiotic versus what should not be. Or, because we don't want someone to be treated. I know sometimes the point of contention can be patients can think, when I get urinary tract infection, or if my urine culture is positive, well, if the patient's not symptomatic, then that's not an indication to treat with antibiotics. You may see some organisms there, but it might not be the most appropriate thing. Once again, if you're treating something that doesn't need to be treated, then that leads them, once again, on that road to C. diff or other infections. Or, antimicrobial resistance patterns developing for people. Severe allergies can develop because of repeated exposure to antibiotics. And there are a variety of other issues that can take place. So think about what you can do in your facility. Now, at Milford Regional, we have made it a practice of reaching out to the skilled facilities in our area. These skilled facilities are not owned by Milford Regional. They're just in that service group, side of that service area. But we want to make sure that we all are thinking kind of with the same mindset. We don't want to change policy necessarily for them, but we want to make sure we're all on the same page about what is current thinking and current actions. So we have kind of a plan with them where they call us if they have a problem, and physicians' practices as well. We consult with them and just work with them to help understand what's the most appropriate care related to our areas of expertise here in the hospital. And that seems to work out well. Now understand that their practice works both ways because we learn from them as well as they learn from us. So it's really been quite effective. So once again, we work for that hospital expertise with pharmacists at Milford Regional. We already said they do a great job with this, and they do. They work on antimicrobial stewardship each day, so this is the next slide. The pharmacy team includes, but isn't limited to, the pharmacy director, staff pharmacists, one of whom is actually in the middle of a program for certification for antimicrobial stewardship and pharmacy candidates. So also, our microbiology supervisor works with us within the hospital, but also I think works with some of the outside areas in bringing new tests to Milford, which aren't limited to our inpatient patients, but also to outpatient areas as well. So in addition to that procalcitonin testing that we previously described, he also has been instrumental in bringing in PCR, or those rapid molecular tests for flu and flu RSV since actually 11/16, so November of 2016. And we've seen actually that we've been able to capture more of those patients with flu, as being positive. In the past, we had more reliance on, certainly a rapid flu test, but also just looking at knowing the flu is in the area, and also on did the patient have a temperature greater than 100, and did they have a concomitant cough and sore throat. So now a flu test seems to be more accurate than that had been in the past, and capturing it's more sensitive. That's what it really is more sensitive. And so we have more positives and fewer false negatives. And over the years at Milford Region, we also have rapid MRSA testing for patients and rapid PCR testing for Clostridium difficile for a few years. We've also found both of those beneficial. Next slide, please. So I'd like you to share your thoughts about how you can share expertise, both yours and how you can give it and how you can receive it. So what educational opportunities are available for your clinicians and patients on antibiotic prescribing, and how do you ensure access to needed expertise on optimizing antibiotic prescribing? And what educational opportunities are there for you? And could you have something such as putting information on your website available to your patients and families? And what other activities could you provide for them? Next slide, please. Start small, and it will grow. I love this slide. I have to say, I can't take credit for it. It's just a great concept, but that's it. When we started this program, you saw our road kind of traveling, wandering, and, there's a start point. But there's probably never an end point to antimicrobial stewardship because situations change, new tests are available. Hopefully, new antibiotics will be available also, will be developed and be effective. And as we see patients receiving, appropriate antimicrobial use, we may see, some other benefits from all of this. So when we first started in 2010, or maybe a little sooner, we had the following members on our team. We had the infectious disease specialists, of course, which we're grateful for, pharmacists, including pharmacy students, microbiology supervisors, and infection prevention. But today, that team has grown by a lot. So in addition to some of those individuals, we have our hospitalists. So we have active representation from the hospitalist group that works here at Milford Regional. And really, all staff play a role in antimicrobial stewardship. And then the direct care staff can really play a role in advocating for their patients. We also have patients and families because we're educating them. We ask and encourage them to speak up and advocate for their own care. We have actually 5 SNF partners, so individuals who belong to skilled facilities, some of their medical directors and nurses from community skilled facilities and rehabs. And there's room for more. Remember, we have that larger emergency department now, really doubles in size, and those new urgent care centers. So we really want to look at how we can expand and roll this out to them into the physicians' practices in our communities. Next slide, please. So I think I covered before some of the committees to whom we report antimicrobial stewardship activities, but this also includes Department of Medicine, Department of Emergency Medicine, the ICU, course infection prevention and control, the pharmacy and therapeutics, and even patient care services. So, and information is also provided to physicians and staff at skilled nursing facilities. Not only do they get this directly from us in terms of minutes and other updates, but also when something is significant, Dr. Newstein actually communicates with them through letters, emails, memos. So we've been quite happy with how that's been working out. Next slide, please. So recommendations for outpatient providers. You can see once again that you see no end point on this road. You know, the destination always changes, but the journey is always interesting. So, and you see those milepoints along the way. And some of them are slow going, and some of them really can speed down those hills. There's no time like the present to get started. You're not alone. Collaborate with each other. Collaborate with maybe hospitals in your area and hospitals. Collaborate with your skilled facilities. And join organizations such as this New England QIN-QIO Antibiotic Stewardship Collaborative, because you'll have peers with whom you can work. You can share and gain ideas and partner with the local hospitals, as I said. And once again, be one of your patient's strongest advocates. Engage your patients and empower them with the knowledge and share what works. Next slide, please. So some of the other things you can do, and you may think, well, what does flu vaccine have to do with the antimicrobial stewardship? But it has a lot to do with it, because you want to provide flu vaccines to your patients and healthcare workers. You want to assess patients for flu vaccine and provide this if appropriate, and get a flu vaccine yourself if able. You want to reduce the risk of getting and spreading flu, because this also reduces the risk of secondary bacterial infections from the flu. No infection means no need for antibiotics. That's kind of like one of the great things about antimicrobial stewardship. Yay. So, next slide, please. And here's some more ideas. Stop the spread by following hand hygiene and other infection control measures with every patient. And implement yourself. You know, every moment of every day, think, oh, you know, what can I do to minimize that risk? You know, use that hand sanitizer or that soap and water. And Bonnie and I never think there are too many opportunities for washing your hands or sanitizing them. There's never a bad time. But also, you can gain more information and more ideas from the Centers for Disease Control and Prevention and other professional organizations such as SHAE, the Society for Healthcare Epidemiology, and IDSA, you know, the Infectious Disease Society of America. So here are some of the websites that you could use, and maybe you'll share with each other during this collaborative websites that you go to for information, because we would love to have other resources available to us as well. Next slide, please. This is just, you know, that viruses or bacteria, let's get used it, you know, that get smart about antibiotic use that we share with our patients and with our colleagues. And it's accessible on the CDC website. And it's accessible to you and made for distribution. You don't have to worry on something like this about copyright laws. They really want the word to get out there. And I know you do too, as we do as well. So, next slide, please. I just want to give special thanks to Milford Regional's Antimicrobial Stewardship Committee, and of course our administration, because they helped make it possible. Bonnie Burke, my associate in infection prevention and control, to Suzanne Salem-Schatz, who actually was the person who is really the facilitator with us for the Massachusetts Coalition for Prevention of Medical Errors for those early C. diff reduction collaboratives, and she's the one who actually helped us to engage with CDC on those antimicrobial stewardship calls, and also to get us really thinking about antimicrobial stewardship. Obviously, also the Massachusetts Hospital Association and the Massachusetts Department of Public Health, who we see as real partners with us, and we cannot thank all of these individuals enough. Next slide, please. So, remember, don't go it alone. Embrace community antibiotic stewardship, and we want to thank you for not only participating in this, but also for letting us speak with you today. Next slide. Okay.
Thank you so much, Kim. This is Carol Dietz again. Thank you very, very much for your outstanding presentation. We now want to hear from the participants. We would like you to, if you have any questions to pose to Kim, or if you would like to share your own experiences concerning implementing an antibiotic stewardship in your facility, whether it's in a hospital, a pharmacy, a nursing home, an emergency department, we would love to hear from you. To unmute your line, we would like you to press #6. That will unmute your line. So while you're getting into that mode of asking your question or posing a comment of my question, I would like to ask Alyssa or Maureen to address some of the comments or questions in the chat box.
Sure. This is Maureen. We have a question from Lisa B. And she says, we are doing many of the elements within the program. I'm working on tying it all together. I'm interested in knowing exactly what information data should be reported in a monthly meeting. I guess she's asking you that. I know you referenced that there were some monthly meetings and report outs. So what exactly do you put in those?
This is Kim. As I said, we've had some difficulties with being able to get electronic reports that sit out the data first, so to speak. Although spinning doesn't seem like a good infection control technique. But what we do report on is that we have implemented some of the results of the testing. We wanted some patients for, heavier antibiotics gone beyond 7 days, and if they have, what were the indications for doing so, and also drug-bug mismatches on some of the things that we talk about. So drug-bug mismatches is something, and that's what we do. And as I said, that testing and anything new that we're exploring, and also we, at those meetings, get feedback from the providers, and I'm meaning from the microbiology specialists and from, and a microbiologist who attends is Greg Berman, who, kind of like we're glued to him, as one can imagine. He's been fabulous in facilitating processes for us. So we don't necessarily have high numbers all the time, but what we do is show what activities we're engaged in any related to those activities.
Thanks, Kim. We have another question from Christine Kody. What and how are you educating the doctors on the amount of antibiotics they are prescribing?
Well, actually, activity, Dr. Newstein, an infectious disease specialist who is also actually chief of medicine at our facility, communicates with doctors regarding that. He provides direct interventions if needed, as does our pharmacy on a daily basis when they look at drug-bug mismatches. They will call the provider and say, what actions would you like to take. Microbiologists work closely with the pharmacists when they notice a drug-bug mismatch, and it gets facilitated directly with the physician. And then they have the option of, adjusting medications if needed. And Dr. Newstein also shares with them current knowledge, as I said, sends emails and, memos, communications, and also educates for orientation for individuals and for, during the medication.
Kim, do you have on your formulary specific antibiotics that you have to get pharmacy or ID physician approval, or they're the only ones that can write those prescriptions?
Yes, we do.
You do?
We have, there are some that need prior approval, as I said, some that need approval in providing it, and, so that is something that we do. Thank you.
Oh, there are no questions in the chat. I don't know if there's anyone on the phone.
Okay. Thank you. Thanks, Maureen. Anyone on the phone would like to ask a question of Kim? To unmute your line, it's #6. And then to mute up again, it would be *6. So #6 to unmute. And also make sure you haven't pressed the manual mute button on your phone as well. It's like a double mute. Thank you, Morgan.
In the chat, since there isn't anything yet, and I don't think there's anyone on the phone yet, George McGarrett wrote that they have an antibiotic stewardship newsletter for medical staff. So I was just curious to ask him, if he is still on the call, if it goes to all medical staff, or is this a physician group? It doesn't say where he's from, it just has his name. And maybe if he is on the phone, he could speak a bit to that. It seems like a great idea to touch everyone in your medical community.
Yes,
who does the prescribing of the drugs.
We've just started doing this with our medical staff in-house at the hospital. We plan to extend it to our medical community, especially those in long-term care facilities. And we're just trying to give them some initial data so that they'll be aware of the program, and so they can try to guide them for appropriate selection based upon some of the things we've talked about today. And sometimes they just need reminders about, switching IV to PO. We like to show trending. Sometimes antibiotic or antimicrobial use is seasonal, so it's reasonable. We understand it. Sometimes it's not. And then lastly, sometimes, and again, this is one of the least important, but very important, is the economic differences. So this is something we're just in the initial works of getting on board with. This is our plan for our stewardship program.
Great. Are you asking them to kind of work, I guess you have an electronic medical record, I'm assuming, and
yes, we do.
Looking at drug dose duration, and then are you asking for a reason for the drug, the antibiotic?
We'll have our pharmacist assigned to the antibiotic stewardship rotation or duty for that day to look at certain parameters, either certain select medications or certain lab results, to try to isolate in on those. So unfortunately, our current staffing levels, and we don't have students at the moment, sometimes we do during the year, don't allow this to be all-inclusive, so we're rather selective in our parameters right now.
Oh, okay. Because I've been hearing that that's a big thing from the nursing home side, that they come over with an antibiotic and sometimes they don't know the reason, and that's why we've been asking them in our antimicrobial task force to see if it can be also put in that order or reason, so that the rest people know why the patient's on, because sometimes they're on it for another reason that wasn't like their principal diagnosis or even a secondary diagnosis.
Well, we try to rely upon med reconciliation information to do that, and if that's not clear to us, either a follow-up call to physician or a pharmacist visit to the area or the patient care area to try to ascertain whether it's appropriate, whether it was for a particular indication before, even whether it should be continued. Sometimes, unfortunately, they'll come in with antimicrobials that should have been discontinued days ago, so we try to encompass that up front.
Oh, that's great. Thanks.
Excellent. Thank you so much for that information. So we have one more minute before we can say I'm going to have my final slides. Anyone would like a question? #6 to Kim?
I think we have one more.
Okay.
There's a question from Ken E. And for Joint Commission purposes, how do you document the competence of the staff involved? And also, how do you assess the quality of the recommendations being made?
Well, we're working on that. Of course, our infectious disease specialist, the board certified, so that gives them some qualifications. We have, as I said, a pharmacist who's in the middle of an antimicrobial stewardship certification program, so they're working on that. And, I think staff work together so that they can feed off of each other's expertise. So we have our pharmacists, and I should have mentioned this before, actually participate in rounding on floors in the morning. And so they work with all of the staff in, determining what's appropriate for patients. And also we had just a recent antimicrobial stewardship roundtable where regional hospitals had sent physicians, staff, and pharmacists, and long-term care facilities did the same, and also members from the Department of Public Health participated with us, so we could share information to make sure we're all on the same level with the information we're using.
Great. I think that's it, Carol.
Wonderful discussion, wonderful questions. Thank you so much. So, the key takeaways. I would like to thank Kim Knox so much from the Milford Regional Medical Center for your thoughtful lessons learned on implementing a community-based antibiotic stewardship. As we have learned, we need to implement antibiotic stewardship in all healthcare settings. It is truly a matter of patient safety. It is one of the most important strategies to combat antibiotic resistance, which is among the greatest public health threats of today. Every healthcare center and healthcare provider has a role, and we all need to be antibiotic stewards. The hospitals need to expand their hospital antibiotic stewardship work to their emergency departments, their urgent care centers, and reach out to their community partners, as well as reaching out to their physician offices and clinics, which is just like what the Milford Regional Medical Center did. So here's my second ask. Remember, my first ask was, as you're listening to Kim's presentation, you were thinking about your own antimicrobial stewardship and your facility and where you are in your journey and whether you need to implement to start off with a commitment, or you're in the middle of all four core elements and you want to enhance the four core elements. But what I would like, my second ask is to join us, to join the New England QIN-QIO in implementing an antibiotic stewardship in your outpatient settings. This is vital work, and we're currently recruiting in the outpatient settings, and as I mentioned earlier, the physician offices, emergency departments, urgent care centers, pharmacies, federally qualified healthcare clinics, and walk-in clinics. The resources and technical assistance that we, the New England QIN-QIO, will provide to your outpatient facility is free and will be facility specific, meaning that we will help you with your tracking reporting. It's not a one-stop shop. It's going to be what do you have in place already, or what do you need, and how can we help you? If you feel you are not the right person in your facility to commit to this request, please send us the contact information to the right person, to the right leader in your facility, and we will reach out to them with your guidance. So please join us. The time is now. Each state has an antibiotic stewardship team lead for the New England area, and we would love to hear from you. On this slide is the contact information, the phone number, as well as the email address for each of the team leads within each state, and we would love you to continue this discussion with you and your facility. We hope to hear from you soon. Now, moving on to those pharmacists who are going to claim a continuing education credit, the Accreditation Council of Pharmacy Education code for today is community. You'll be able to enter that information when you complete the session evaluation. For those of you who are not looking for that continuing education credit, please complete the evaluation. We want to hear from you on how we did today. And when you do fill out that evaluation, you will also receive a certificate of attendance. There are other two learning events that may be of interest to you. The first one is the antibiotic stewardship focus in long-term care, which occurs monthly. We just had our monthly one earlier today from 11 to 12, and that was an introduction to antimicrobial stewardship in the long-term care. The next one is going to be on March 28th, and you can see the other webinars that follow. Also, there's the medication safety lunch and learn series, which the next session will be in May, which is May 9th, and that's going to be on anticoagulation in the ambulatory setting, which is showing clinical guidelines and protocols, and the other ones to follow. And there's also a face-to-face learning event in Massachusetts on May 3rd at the Massachusetts Health and Hospital Association on antibiotic stewardship in the acute care long-term setting. And there's also one for Rhode Island, which will be on May 8th, and that's going to be in Lincoln, Rhode Island. So finally, I'm turning this over to Morgan.
All righty, thanks, Carol, and thank you, Kim, for that great presentation. As you can see from this slide, we are now on social media, so please connect with us on Facebook or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, the evaluation will automatically pop up on your screen, and as Carol mentioned, if you're looking for credit for this webinar, you will enter your ACPE code there. If you don't have time to fill it out right now or sharing a computer with somebody, you will be able to fill out the evaluation tomorrow. We'll be sending an email that contains a link to the evaluation as well as a link to the PowerPoint and the location where you can find the recording and transcript within the next few business days. I will put that link in chat again just so you guys have it. But thank you for joining, and be on the lookout for emails about our next webinar in May, as Carol mentioned. Thanks, everybody, and have a great day.
Hi, everyone. Have a great day. Wonderful presentation. Thank you, Kim. Bye-bye.